Good morning, everyone. It's lovely to be with you. Thank you for joining this session. My name is David Vaughan, and I'll be talking to you about some individualised brain mapping approaches that we've used to try and identify surgical targets in people with epilepsy. I don't have any disclosures. Thank you to the team in AV. All right, so today I'm going to present three cases in the multimodal theme of the session today, ictal SPECT, task fMRI, and simultaneous EEG fMRI, and talk a little bit how we individualised them for each patient because it was necessary in that case to do that and how that led us to an answer. So to recap the surgical treatment of focal epilepsy, it's necessary because for around a third of people with epilepsy, anti-seizure medication doesn't work, but targeted surgery or ablation in the right target and the right person can be curative. So we need to identify the brain region that causes seizures. Much easier to do if there's a structural lesion that dramatically increases your odds of a good surgical outcome. So the challenge we're left with is people who either have very extensive lesions or have an MRI negative appearance on structural clinical imaging with difficult to localise epilepsy. The general workup towards surgery starts with a non-invasive phase 1 testing. If the information's discordant or difficult to localise, invasive monitoring with stereo or subdural grids, as Lee has mentioned, and then proceeding ideally to surgery. For invasive monitoring, the essential ingredient is having a good hypothesis. And so that's why today I'm talking about functional imaging. What extra can we add to the standard clinical workup when it's difficult and we haven't got a good target? All right, on to case number 1. Since we're in Brisbane, and you might make a trip to the Gold Coast, this is Movie World and one of their fine roller coasters, which is an excuse to introduce JP to you. Here's a 25-year-old construction worker who came to the hospital after his first seizure. But when we spoke to him, he told us about dizzy spells that had been happening for a couple of years, and he first noticed these when watching online YouTube videos of roller coasters, just like this one. But it wasn't just perceived motion that set off the dizzy spells for him. He also had it when he got on escalators, when going down water slides, even starting off on a motorbike. He'd often get this dizzy spell, and he said, well, I jolt the motorbike a few times, I have a dizzy spell or two, and then it passes and I'm all right for the rest of the journey. So we brought him into the epilepsy monitoring unit to see what these events were. This is him sitting in our monitoring chair. You can see he's got the EEG cap on. And what he noticed while he was with us is that, that tilting back the chair with the automated button, the chair goes back, his feet come up, the chair's a bit wobbly, that this would trigger his dizzy spells. Now, with his spells, he'd remain aware. He'd have an intense sensation of falling backwards. If he was standing up, he wouldn't lose his balance, but he would put his arms out as if he was about to fall over. And he'd go still and quiet for a few seconds. Recording the EEG of this, we confirmed their seizures. The scalp discharge is a compressed EEG, so it's hard to see, starts here. So back here, this is where he tilts back his chair, his symptoms begin. So 4 seconds after that, we were ready and waiting, and this is where we individualised the study. We did an ictal SPECT study, so we injected a radio tracer that binds to brain regions of hyperfusion during the seizure onset. So we were ready and waiting. He tilted the chair, induced his event. We did the injection. And then about 10 seconds later, we see this scalp ictal rhythm, which runs for another 10 seconds or so, ends. Maximal in the midline, maybe a little bit more on the right than the left. It's a subtle signature, not easy to show you, but it was reproducible over 30 or more events that we recorded. So what did the ictal SPECT show? It showed this really focal hotspot in the midline parietal cortex. And so we always do a baseline study when he's not having a seizure and do a subtraction. And doing the subtraction and co-registering to the patient's own T1 imaging, we had this exquisite hotspot here in the right cingulate sulcus. So this is a really interesting brain region that's been linked to integration of self-motion. It's got strong response to optic flow, but only optic flow of yourself moving, not of other objects in the environment moving. It has inputs from the vestibular system and proprioceptive connectivity, more with legs than arms. So this is a beautiful review by Smith from a couple of years ago, strongly proposing this region integrate sensory motor information for control of locomotion. So it really explains why this kind of stimulus was able to trigger seizures in this man, and also the expression of his seizures starting in this brain region. I've told you about someone with reflex epilepsy without saying anything about reflex epilepsy. So it's when seizures are consistently triggered by a specific stimulus. More common in generalised epilepsy with the photosensitivity, but does occur in about 7% of people with focal epilepsy, and there's a wide range of either sensory, motor or cognitive triggers. But the important thing in focal epilepsy is that the trigger indicates the brain network or brain region that correlates with the seizure onset zone, so that we can map the trigger to give us localizing information as well as mapping the seizure, which brings me to case number 2. So this is Amber, and she's been public with her story, so if you'd like to hear it in her own words, please check out the link. But I met her when she was 22 and she was having daily seizures, mostly triggered by brushing her teeth. Every time she tried to brush her teeth, she'd get dystonia, tightening of the right face, her right shoulder would twitch, and then sometimes her face would twitch as well. She might zone out a little bit. All the events were also triggered by other things. She was on 3 anti-seizure medications, they just weren't working. So we went through our standard mapping, a pre-surgical workup approach. The video EEG, we recorded seizures in the left pericentral region. She didn't have any interictal discharges, which means we can't do EEG fMRI easily. Structural MRI, no definite lesion, although we looked hard at the left pericentral region. FDG PET, mapping glucose hypometabolism. There was some regional hypometabolism over the left pericentral region, and SPECT, the same thing, some hyperperfusion with seizures, but unlike the last case, not focal enough to give us a target. So how we individualised here, we designed a custom fMRI paradigm for Amber, which was brushing her teeth in the scanner. So this is a video here looking down the bore of the magnet. So her head is in the coil just facing us, and you can see that she's brushing her right molars with her left hand. We did block design, cued by a visual stimulus, brush, rest, and we used the opposite hand to the side that most often triggered her seizures so that we could disambiguate the hand motor and sensory activation from the mouth, jaw activation, sensory activation. And we got her to practice this in the mock scanner. We tried different things to make sure she could stay still. Again, multi-band, multi-echo, fMRI acquisition, and we had an observer in the scanner room watching to see directly whether any seizure was occurring. So we had respiratory and pulse monitoring, and our intention was to do, like I said, the block design, and then midway through the first block of brushing, you can see her respiratory trace here flattens, she stops breathing regularly. She was meant to be brushing, she pauses, and she had a seizure for about 40 or 50 seconds. Offset of the seizure noted by the observer. So here's the fMRI analysis of her task of the brushing, and we see both activation over the right motor cortex, sensory motor cortex of her left hand, operating the toothbrush, and then over the left hemisphere, more of a lateral view, a cluster of activation regions in pre and post central, some corresponding to the gum and mouth areas in the operculum there. And here's the activation during her seizure, which we modelled as a block design, with this much more focal region of activation over the left precentral gyrus. So we really zoomed in on this area with our structural imaging. There was this suspicious but not definite region in the precentral gyrus of subtle thickening of the cortex, maybe a hint of a tail here, which was suspicious but not definite for a transmantle band. And so we went on to stereo EEG by co-registering the fMRI with our neuronavigation system. We were able to place 2 electrodes, X1, X2, directly through the suspected lesion site. and the stereo EEG confirmed that that was indeed the seizure onset zone, epileptogenic zone, and we're able to deliver radio frequency ablation. So with that treatment, we're passing high frequency current between two adjacent stereo G contacts to produce a small burn, and you can see that as this black spot here. And the great outcome for this very small lesion of really only a couple of millimetres in size, the AMBER since then has been seizure-free over the last 3 years. Now, really, radio frequency ablation is one of the few treatments that we could offer in this situation with a focus in the precentral gyrus, high risk of motor deficit with any resection there. Indeed, with even a small ablation, she had subtle lip weakness for around a month, which fortunately resolved. All right, very quickly, the third individualised case is this gentleman who had hypermotor seizures since he was 18, at night suddenly from sleep, leaping out of bed, turning to the left, spinning around, collapsing on the floor. His EEG showed a frontal discharge, it was midline, not well lateralised. His MRI had no localising lesion. On PET, we thought maybe the right hemisphere, maybe right temporal, but the clinical hypothesis was frontal, so we thought clinically probably right frontal lobe. Because it wasn't well localised, we went on to do simultaneous EEG. He had these beautiful bursts of frontal fast activity, which we modelled with, we're able to capture in the scanner and model both with a general linear model. But what I'm showing you here is an event-related independent component analysis decomposition, which we find really very helpful for separating out different components of the response to interictal discharges. And that gave us the sense that there was actually much more activation on the left frontal lobe, not right. And that changed our planning for stereo EEG, and where we'd initially planned a right hemisphere implantation, we added these two extra electrodes on the left. And as it turned out, that made all the difference. We confirmed that the seizure onset zone was actually in the left anterior cingulate. We went on to deliver radio frequency ablation via those electrodes, and he had 4 weeks of seizure freedom, which was excellent for him, and a good marker that we're on the right spot. His seizures returned, and so we proceeded to a focal resection here of the left anterior cingulate and mesial frontal lobe, which has given him quite a good outcome. He's been free of nocturnal seizures over the last year. He still has occasional daytime seizures, so an ILAE class 4 outcome, but one that he's been very pleased to proceed with. All right, so I'm just going to skip over this slide in the interest of time. So when to attempt individualised approaches for functional imaging, it can be a powerful tool for difficult to localise epilepsy when you've done all your standard things and you're thinking, what else can we do to localise the epileptic focus, or just get a hypothesis for the epileptic focus. Great in MRI negative or extensive multilobar lesional cases. And reflex epilepsy, I think, is a special opportunity where we can really trigger seizures, get to understand the significance of the stimulus and the response it produces. There are some caveats. These kind of individualised approaches are time-consuming. You do need a specialised and multidisciplinary team, and it's really best done in a clinical research context. And you do need to be doing it in an appropriate ethical framework. And I'm very grateful for my multidisciplinary clinical colleagues. And I should say that while I might be analysing the imaging, it's one of my other neurology colleagues who's planning the stereo EEG implantation, and I think that helps keep an appropriate perspective on the data and the weight to place interpretation. So to wrap up, accurately defining the epilepsy-causing brain lesion can be life-changing. Reflex epilepsies give us a special opportunity. Functional imaging tailored to an individual can sometimes give us an answer and teach us something about the brain along the way. And non-invasive functional imaging is really highly complementary to invasive EEG mapping approaches, and I think that's really where the skills and techniques from this research community are immensely valuable. Thank you all, and I'd like to acknowledge all the multidisciplinary and multi-institutional teams involved in the work. Thank you.